Well, hello and welcome to the 27 Degree with Chris and Nancy. Today we'll be discussing hand surgery with Dr. Mahmood. Before we begin our conversation, I would like to thank our sponsor, Bay Coast Bank. Bay Coast Bank is just right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. As always, you can support the 27 Degree with Chris and Nancy by subscribing to us on YouTube or your favorite podcast platform, and by following us on Facebook and Instagram. Also, please remember to leave a review, and 5-star reviews are, of course, greatly appreciated. So first of all, could you tell us a little bit about yourself?
Sure. Well, thank you for having me. So yeah, I grew up in Sharon, Massachusetts, so not too far from here. I went to college locally at Brandeis University, and then I took a year off before starting med school in Albany, New York.
Great.
I was at Albany Med for 4 years, and then I ended up staying in New York for residency at Maimonides in Brooklyn. And then I just finished my hand surgery fellowship at NYU. Those last 6 years at New York were a big change for me. I got married then. We had our first son.
Great.
So now it's back home for us. Thank you. Yeah.
What's your baby's name?
Oh, Amir.
Oh, nice.
Yeah. So now we're back
Nice.
home. It's good to be back.
That's
my parents
great.
and both my brothers are here as well. So
Oh, sweet.
Yeah.
Very nice. Well,
Excellent,
congratulations.
So for hand surgery, just so the audience understands, you initially do an orthopedic training program, and then it's after that. Is that correct?
Yeah, so there's a couple pathways to it. So hand surgery, being a hand surgeon means that you've done a hand surgery fellowship, and there's general surgeons, plastic surgeons, and orthopedic surgeons who can also all
Okay.
do that fellowship. But for the most part, it's general or plastic surgery and orthopedics. Both
Okay.
have that pathway to do become a hand surgeon.
Yeah, I never heard of a general surgeon doing that, but I didn't know that. That's interesting.
It's less and less common now. It's
Yeah.
really just it's almost like 99% probably
Okay.
orthopedics and plastic surgery.
Right. And orthopedics training is how many years?
It's 5 years.
5 years, and then hand surgery is
Hand surgery is 1 year.
1 year. So
Wow.
6 years after medical school of
Yep.
training. That's a lot.
Yeah,
It's commitment.
it's not all bad though. It's
No.
you always work with a good group of people, and yeah, I definitely enjoyed it.
Great.
When did you know you wanted to be a hand surgeon?
I would say it's probably sometime in the middle of residency. So orthopedics residency is a lot of fun. You get to see a lot of different people, younger pediatric patients, older adults, and the elderly, and you get to
Yeah.
work with a range of people. And I thought hand surgery was the most interesting part of that because not only are you fixing bones, but there's also a lot of tendon issues, ligament injuries, and people with arthritis, people who are like very active, athletic, or just older people who have had problems for a while. So you get to see the whole range. And I thought within orthopedics, I thought hand surgery had the most variety, the diversity of cases, and the diversity of people you get to work with. So
God bless you, because
definitely
looking at my hand, it looks pretty intricate. I'm just like, I can't. Like, you gotta be pretty
A lot
smart.
going on there in the hand. A
Yeah.
lot going on.
Yeah.
Yeah.
It's very there's a lot of little pieces here to make everything work all right.
Yeah. So what makes the hand so unique? Let's talk about that.
sure, yeah.
Good
So
segue.
so yeah, it's definitely a complex structure. If you think about it, there's 27 bones, there's ligaments, tendon, nerves, blood vessels, and things like that. So it's very, very complex, and all of these things work in synchrony to make sure that your hand is functioning well. So with that, there's a lot of things that can go wrong, a lot of different pathologies that can present themselves. So for that reason, I think that's what makes hand surgery so interesting. You're dealing with kind of all of that. And if you think about your hand, it's basically an extension of your wrist and your forearm and your elbow. So issues with your elbow, forearm, and wrist can also present with pathology to your hand as well. So it's all kind of interconnected.
Interesting.
So when most of your cases, they're more like injury based or they're not congenital. Do you ever do anything like?
Yeah, so it's
Yeah.
definitely a bit of both. So you'll definitely have people who come in just for like nagging complaints like pain, aches and pains, or numbness and tingling like a carpal tunnel syndrome or like a tendonitis. That's probably the majority of things that we see. But then you also have patients who cut their hand on something, who had a bad fall and have a bad wrist fracture and things like that, or they've cut a tendon or cut a nerve or things like that. So it's a bit of both, which also makes it fun because you get to see patients who have had issues for a while and they're finally sick of it and you get to help them, or you have people who just were perfectly healthy and one day that had something wrong happen and you can help them too.
Yeah, and that must be rewarding because you can really make a big difference with you can't really live that easily without your hands, so you really impact on quality of life quite a bit. I'm
Yeah.
sure.
definitely.
And this is so different than general orthopedics. And I know you still do general orthopedics too, because we discussed that the other day.
Yep.
You do?
But
Yeah. So I take general ortho calls, so hip fractures,
My
ankles, things like that
gosh.
that come in.
but that's
God,
such
you're a
a,
superstar.
I mean, that's like so different than what
Right.
you're doing in the hand, which is probably requires a lot of finesse. And I'm thinking when you're doing a hip fracture and you're, getting that hip back into place and putting nails in and plates and all that, it's much more. I don't want to say, I don't know what the
Like
right word is,
fragile
but
surgery, like
right,
Yeah.
that's more rough.
Yeah.
Considering
Yeah, I guess you
compared to
could say
hand
that.
stuff.
Yeah, definitely. But I would say that a lot of the same principles apply,
Okay.
especially with like fractures and things like that. You want to get things in the appropriate length, alignment, rotation, and like a lot of the same implants that we work with, like plates and screws, are just on a much smaller scale. But the
Okay.
same principles of fixation and things like that
Okay.
apply. So that training is still really valuable for anything that you do in the hand, wrist, elbow.
That's great.
Are you using the Da Vinci machine like for this, or are you just going like right in there?
No, so that's more of a general surgery thing, as far as I understand,
okay.
or laparoscopic surgery.
Okay.
We do use we do certain cases with cameras. That's called like arthroscopic surgery.
Okay.
When you put a camera inside like your like for a shoulder, you can do an arthroscopic rotator cuff repair, or even for the wrist. A lot of times that you address wrist pathology with just putting a camera in a small instrument. So it's similar to, I guess, a Da Vinci, but it's on a different
Yeah.
scale. Yep.
Yeah. So now when you see people in the office, you see like surgical candidates, and then you see some patients that don't necessarily require surgery. Can we kind of start with that and just like what do you see in the office that you maybe give different treatments to?
Sure. Yeah. So there's like I would say the vast majority of people thankfully don't need surgery.
Oh.
And you can kind of categorize that based on like what a patient would want to come and see a hand surgeon for. So I would say if I had to categorize it, the most common things we probably see are like a trigger finger, which is kind of like a tendonitis of the fingers to your hand, up to the tendons of your fingers that causes pain, clicking, and catching. Carpal tunnel, which is extremely common, where patients get numbness and tingling and pain in their hand as well. And then a lot of patients who just have arthritis. So arthritis, if you think about it in your knees or your hips, affects your hand a lot as well. And patients can have arthritis mostly at the base of their thumb is what we most commonly see. So to answer your question, I know this is kind of long-winded, but a lot of those patients who've had pain for a while or for things like that can come in. But then we also see patients who just had a fall, like a bad injury or a laceration or a cut nerve or tendon, something like that, that would need to get seen more urgently to be addressed.
Yeah.
Are any of these things, and excuse me, I don't know a ton about this
Sure.
this subject, so I might ask you some things and you're like, well, that's a silly question. But are any of these things that you treat hereditary?
Yeah, certain conditions definitely are. So again, I just started practice, so I haven't seen a ton of like my own
Sure.
personal patients yet. But patients come in all the time with like congenital hand issues, so things like syndactyly, where like a patient was born with two fingers that are stuck together without a gap in between them. That's something that can be commonly seen. One that's really common in terms of a congenital condition is polydactyly, which means that you have like an extra finger, and that's actually pretty. I wouldn't say it's common. It's not uncommon, but things like that certainly do come up, and so things, and then other conditions such as like rheumatoid arthritis can cause. It's a hereditary. In some sense, I guess it's a hereditary condition, and that can cause different pathologies as well. So we certainly see that.
So when someone comes in with an extra digit, is it just you're thinking automatic removal, or that's the way we go these
It's hard
days?
to find 6-fingered gloves, so probably that's where you end up.
Yeah.
I don't know if it's any benefit to an extra finger. More
Generally,
rings.
Yeah, so a lot of people, or if patient has that, it can be just like a small little
Yeah.
nubbin, which if a newborn in the nursery was born with that, sometimes they tie a suture around it and it can come
Right.
off on their own. A lot of times if it's a little bigger, you wait till the patient is like around 1 year of age before you do anything.
Yeah.
But generally, most patients aren't happy with something like that. So
Yeah, a friend of mine, his child had that, and that's exactly what they did. They kind of put a suture around it.
oh, okay, yeah.
It was a small.
That's
extra
probably the
digit.
most common way it presents.
So let's talk about some of the common diagnoses that you mentioned initially that patients
Sure.
come in with. So carpal tunnel, I see a ton of carpal tunnel too. It's so common. Maybe you could describe to the audience exactly what that is and what they would experience and what you do for it.
Sure. Yeah. So again, like you mentioned, extremely common. And what you may present with is basically you'll have some numbness and tingling in your hand. Most commonly, it's going to be your thumb, index, and middle finger and part of your ring finger. But a lot of times, it's not that specific. A lot of patients will come in with like numbness of their whole hand, tingling sensations. You feel like you have to shake your hand after a while to get rid of it. A lot of times, patients will wake up in the morning with that kind of sensation. So those are the things that the patients will most commonly present with. Thankfully, most people do get better without needing a surgery or anything like that, but it definitely warrants being seen by someone and receiving treatment.
Is it always on your dominant hand?
No, it can be
Oh.
either.
And
That's a good
does
question.
it usually just like hit one side, or is it like both sides?
From what I've seen, most patients have like really bad on one side, and then sometimes
A little
just as
bit.
bad or a little bit on the other side. But it can be just one side. I haven't seen it to be preferentially one side or the other.
It can be associated with other medical conditions too.
Like what?
Diabetes, hypothyroidism, pregnancy.
Yep.
So-
Yeah. Pregnancy, especially, we see it pretty commonly because you have a lot of fluid shifts at that time, and that causes so I guess I should mention. So carpal tunnel syndrome is compression of one of the nerves in your hand, the median nerve, kind of right by the base of your palm. And then when that gets compressed there, that's when you get those sensation of this numbness, tingling, paresthesias in those fingers.
And it can produce weakness if it gets bad enough. You can have atrophy of loss of muscle too. And, so you want to catch it, I would think, before that point.
Definitely.
Some of that probably doesn't come back all the time.
Yeah, that's exactly right. For most patients, they present with those classic numbness and tingling type of symptoms in the beginning. But if you kind of let it progress, if you don't address it, exactly like you said, weakness is something that can be irreversible. So you definitely want to address that before then.
Doctor, does it ever go away? Like is it always caused because you're doing something that's aggravating that area?
It can certainly go away on its own, and sometimes patients have symptoms that kind of wax and wane. A lot of times patients who use like power tools, things like that vibratory movement on their hand can cause stuff like that. But a lot of times patients will say that like, oh, it went away for a few months and now it's back, and like whatever they've tried isn't really working for it.
So what kind of non-operative things would you recommend to a patient first? And I know the answer to this, of course, but for the audience out there.
Yeah. So the first thing I would say is if you feel like you have those symptoms and it's sort of mild, wearing a wrist brace is definitely the first thing that we try to recommend patients do. The reason for and that would be at night. The reason for that is that patients tend to sleep, or everyone tends to sleep with the wrist kind of in a bent position at night, and that causes more pressure on the nerve. So wearing that splint at night helps keep your wrist in a neutral position, not extended, but in a neutral position, and that reduces the pressure on the nerve. We recommend wearing that for quite a while to make sure that those symptoms kind of go away, and that's generally the first line thing.
And then after that, if that doesn't help.
So there's other things that have been described. Occupational therapy can help certain people, and that includes certain exercises called nerve gliding exercises, which basically certain hand exercises to help make sure the nerve is not being compressed during like your regular hand motion. But other than that, if you develop weakness, we can do therapy to help strengthen those muscles. But once the bracings really hasn't helped, the next discussion really is surgery.
Yeah. Injections, I know at one point were done, but I don't see that done as much now. Do you do that?
Oh, yeah.
Does it help?
I should mention injections certainly are an option. It can definitely help patients. The literature in orthopedic surgery, or hand surgery, I should say, shows that they can be certainly like diagnostic and therapeutic, in the sense that if a patient receives an injection and they have relief, that shows them that kind of signifies that surgery would also benefit from
So it's
surgery.
a diagnostic maneuver, but it can be therapeutic also?
Right.
Great.
Yeah.
That's good to know. And the surgery, it doesn't seem incredibly, involved for just so patients understand. It's not like getting cardiac surgery. I'm sure it's involved on your standpoint, but it's safe, it seems.
Yeah,
for most patients.
it's done as an outpatient thing,
Right.
so meaning you go home the same day.
Right.
Essentially, it's a small incision kind of right at the base of your palm, and that helps. And we release the ligament that's compressing the nerve.
Oh.
Yeah. So it's a pretty quick surgery. It is surgery, but it's a small surgery, all things considered, and patients have a pretty quick recovery.
And it
people
seems
do
to
really
work well. I mean, from the patients I know have had it, they seem to respond well. I think the more complex thing with carpal tunnel is trying to figure out if it's not something else. Is it coming from their neck or nerve compression at the elbow? And sometimes that can, it's, I mean, patients don't present classically, like you said. I mean, although it's usually, these three fingers and sometimes the ring finger, patients often come in and they can't really discern where they're numb. It's like the whole hand.
Yeah,
You know?
I would say more often than not, it's the whole hand and they can't really localize it.
Yeah.
That's why seeing somebody, the earlier the better, definitely they'll be better off.
Right.
So once they have the surgery, is there risk of having it come back?
There certainly is, but it's pretty low risk. Yeah, so patients, we always counsel patients that when having this surgery, that tingling and that sort of shooting sensation goes away more readily pretty early. That numbness can last a little bit longer because if you think about it, this nerve was compressed for a while, and then once you release that compression, it takes a while for the nerve to wake up. So
that's a good way of
Yeah.
describing it. So can we talk about tendonitis next and exactly what that is and what causes it and what you do for it?
Sure. Yeah. So if you think about it, you have multiple. You obviously your 5 fingers, but you have multiple tendons going on the back of your hand and the front of your hand. And tendonitis is basically an overused kind of inflammatory condition that causes pain and swelling of the tendons as you're using your hand. It's definitely one of the most common things we see, and I would say one of the most common things I've seen so far is patients with trigger finger.
Yeah.
And what that is basically you have tendons that run to all your fingers, and if you're using your hand a lot, as everyone does, they can get swollen, painful, and inflamed in the tunnel that they run under, and that causes the finger to be stuck in a flex position like that, and then sometimes you have to pop it back in or pop it back out to straighten it.
And it's uncomfortable.
Yeah.
It's not really a good feeling. So
No,
Yeah.
not up for it.
Yeah.
So do you see like our the racket sports more prone to something like that with all the pickleball that's been exploding around the country? Is that like, oh boy?
Yeah, I would say not necessarily from sports. I would say we certainly see more injuries from things like pickleball and things like that, especially since it's more popular now. But I'm sure for trigger finger, like a lot of diabetic patients have. That's probably the most common coexisting condition that I've seen it present with. Sort of unclear. No one really knows. Yeah, and a lot of times patients have trigger finger plus carpal tunnel. Not really sure why either. Yeah.
It's probably an inflammatory component associated with diabetes.
I'm going to call you out on something.
Yeah.
So you've been cracking your knuckles.
Yeah.
What do you think about that?
I've been doing it for over 50 years, so I don't know.
Yeah, no,
that's okay.
that's definitely a common question. I'm sure I was almost certain that was going to come up, but the literature shows that it doesn't really affect anything. So,
Oh, really?
other than irritating,
Slid under the radar there.
yeah, it's not. I have that habit too, but
That's okay
yeah, it's
then.
not it doesn't really. It's not been shown to affect you negatively.
No, but my mother used to always tell me, "Don't crack your knuckles. You're going
Right?
to get arthritis."
Well, you
Everyone
would
says
just
that.
think.
But no, not that I'd recommend doing it, but it becomes a habit that's
Yeah,
out of control.
definitely.
You talked a bit about trigger fingers, and we didn't talk much about like what you do for it. So
Sure. Yeah. So this is one of those things that there's not really a good solution in terms of, like I mentioned, carpal tunnel has bracing and things like that. Certain people you can try like wearing a sort of a splint for trigger finger, but generally our first line treatment is a steroid injection, which we do in the office. It's been shown to be really helpful, and that it works pretty well because it helps reduce the swelling and the pain and the inflammation that patients get.
Right.
But we always tell patients that it's likely that they may need a second shot.
Yeah.
We always hope that this injection works for weeks, months, or forever. But a lot of times, patients generally need a second injection if it comes back.
And I'm assuming with tendonitis, for the most part, that's what you're offering patients from a surgical perspective is injections.
Yeah. For trigger finger especially, I would say if it's my first time seeing someone, that'd be my first line go to.
Yeah.
But again, if it's been two injections and then rarely a third injection,
Okay.
and if they're still not better, at that point we discuss the surgery.
Okay.
And sorry.
No. I was going to say, so tendonitis, trigger finger, they're kind of part of a spectrum then?
Yeah. So we were discussing tendonitis. So trigger finger you can consider, I guess, as sort of a tendonitis, but you also can have what's called Duperrin tendonitis, which is basically affects this part of your wrist, which is basically tendons that help that go to your thumb and help you bring your thumb up like that.
Right.
That's definitely
That's very common.
Yep. Yeah, and one of the most common ways that patients may see it is like a newborn mom.
Yeah.
Because when they're holding the baby
Right.
like this,
Yeah.
yes, I think it's called like
Oh.
like mother's wrist or something like that.
Yeah, I'll show you how you check for that. Let me show you. Put your thumb inside
Are
your
you
hand.
gonna hurt me?
No, I'm not going to hurt you. Put your thumb inside your hand. You go like that, and then you go like this. It's called a Finkelstein maneuver.
A Finkelstein.
Yeah, and it's the tendon right here, and it hurts when you palpate it often.
So I'm
So-
clear. I'm good.
Yeah, you're fine. You don't have it. Correct me if I'm doing anything
No,
wrong.
that was perfect.
And then the other thing we see a lot of is Dupuytren's contracture.
Right.
And
Right.
that's can be really deforming to patients.
Can you say that again? I missed that.
Dupuytren's contracture. So you see
Dupuytren's
patients,
contracture.
they have like usually a bunch of lumps here, and their fingers are kind of sometimes
Yeah,
contracted
yeah,
like
yeah,
that.
yeah.
So that's a Dupuytren's contracture, and they literally cannot extend their finger. It's stuck in a flexed position. So you can think if you have 3 or 4 fingers like that, or even 2, how do you function? Because you need you have your opposable thumb, but now you can't use these fingers. I mean, that's difficult. So
Yeah, pretty disabling.
it is really disabling.
Yeah.
So what do you do for that?
Yeah. So just about this, you mentioned hereditary conditions. This is definitely one of them. So a lot of people with Northern European ancestry, that's generally where we see it, but it can be from people from other backgrounds as well. So there's a spectrum of disease with anything, and this one is the same. So a lot of times patients will have exactly like you mentioned, like just a lump in their hand, and it's not associated with a contracture of their finger, meaning that their finger's not stuck in a bent position. And if that's the case, you don't do anything. It's generally not a painful condition, and patients can just kind of live their life. However, when patients start to develop like a deformity of their finger where it's really stuck in a bent position, that's when you sort of discuss different treatment options. Other people, some surgeons recommend something called needle aponeurotomy, where you stick small needles to kind of break up that tissue that's kind of making the finger stuck. But generally, what I would recommend is a small surgery, which involves removing that pathologic or diseased tissue that's causing the finger to be bent.
Oh.
Yeah.
Primacare is Southeastern New England's trusted leader in medical care. With offices in Fall River and surrounding communities, we're dedicated to your well-being. Our carefully selected team of more than 150 providers offers world-class primary and specialty medical care. Primacare doctors are supported by a skilled staff trained to deliver comprehensive radiology, imaging, and testing services. Primacare is large enough to take care of all your medical needs, but small enough to care for you personally. Primacare is by your side.
So can we back up and talk about arthritis a little bit too? You mentioned
You read my
rheumatoid.
mind again.
What,
I was just going to
please?
ask that. You read my mind again.
Oh, I don't want to read your mind. It'd be too scary. That was our show yesterday.
Yeah, that was a scary show.
But with the rheumatoid arthritis, can you just kind of describe what that is, and then talk about your magic on how to deal with that?
Sure. Yeah. So there's different types of arthritis. Classically, in hand surgery, rheumatoid arthritis is something that was like a few decades ago you would see much more commonly, and that's like an inflammatory condition that would cause like wear of the joint cartilage. Much more commonly today is what we see is osteoarthritis, which is basically what like in hip or knee arthritis, where it's just wear down the cartilage over time. And if you think about your hand, there's joints in your hand as well, and a lot of the same disease processes cause you to have that wear down of the cartilage over time. And the most common place we would see it is in the this joint of your finger, like the very tips of your joints, and it can be swollen and painful for patients. And a lot of times at the base of your thumb is where you see it as well.
For osteo.
Correct.
Yeah.
Yeah. Osteoarthritis.
Yeah.
Does the technological world we live in, what gives you the oh my God, this is gonna like really explode because we're using our hands differently than we did 20
Like on our
years ago.
phones when we're doing all
With
this
all the
stuff with our
texting and with
thumbs.
the computer boards and
Yeah, that's a good question.
game
honest-
errors.
Right. Yeah, that's a good question. I'm actually not sure what the answer for that is because it's not.
I'll get
not
back
that-
to you in 20 years.
Yeah.
Yeah, we'll have to see what happens over the next 10
It'll
years.
be
I
a
guess.
follow-up
Yeah.
part 2.
But as far as like osteoarthritis of the thumb, of this
Right,
joint here,
yep.
women get that more commonly than men, it seems.
Yeah,
Why is that? I've always wondered that, and I don't know the answer, but it's definitely more common in women than men.
Yeah, you're exactly right. I think this is what we call basal joint arthritis, arthritis of the base of your thumb. I think it's something like 5 times more common in women, and I'm actually not sure what the answer is.
Yeah.
It must be some like I'm blanking on the word for it, but there's maybe estrogen component
Maybe
or
it's a
something.
hormonal issue.
Yeah, I think
perhaps?
maybe that's what it is, because even for so like shift gears, ACL ruptures
Right.
are like 10 times more common in women than men. And so there's a lot of theories behind that. And so, yeah, certain things just happen much more common.
That's interesting. That's interesting. I mean, there's, so I'm just thinking back to that. I never really thought about this, but, with pregnancy, there are chemicals and hormones that are there that kind of really relax the cartilage in the pelvis so
Right.
that, the baby can be born. I wonder if part of that is related to some of the hormonal things that occur in women that don't occur in men.
Yeah.
Interesting. Yeah, that's a good point.
Dr. Mahmood, do you see certain disease processes at certain ages? Like 20s and 30s versus like 40s and 50s versus later in life?
Yeah.
Like 70s, like Nancy.
Don't I look good?
Yeah, certainly. So like a tendonitis type thing, I think that can happen really at any age, but really more like young adult to like later in life. I think that's definitely more common. Arthritis definitely later in life. Patients who are laborers or like do a lot of manual heavy lifting, they can have that much earlier on. And so there's a age component to it, but also like an occupation and like activity level component to it as well.
Yeah, a lot of my patients who are laborers, which there's a lot of in this area, I just feel bad when they get older. They get past 50, they have a lot of arthritis issues.
Right. Yeah.
It's really they beat up their bodies.
Yeah.
No doubt.
It's not an easy work that they do.
And then weightlifters, I see a lot of joint injuries over time with weightlifters. People who are doing powerlifting and that.
Yeah.
They
Absolutely.
They do a lot of damage often to their shoulders and that. So
absolutely, like boxers or things like that.
Oh my God, you must shiver when you see a boxer come through your door.
It's just your hand and your wrist weren't designed for that kind of impact.
No.
So
repeatedly over years and years and years, right? Oof. So in that same vein, preventative stuff we can do to keep our hands in the best shape possible. Like, what are some things you're like, oh no, please don't do that. I'll see you like in 10 years and you'll be my patient for the rest of your life.
Right.
Like versus, that's good. Keep doing that.
Yeah. So, I mean, a lot of the things that I would say for preventative stuff would be just kind of injury prevention. So like fall risk and things like that. You were mentioning how pickleball is so much more popular now.
Yeah.
Things like you just kind of being more cautious and a little more wary. I think that'd probably be the best thing. People need their hands for daily life, so it's not, you can't like guard against tendonitis or things like that. I think you just kind of need to use your hands as much as you like for labor or your activities of daily living. So it's hard to say that there's like a good preventative measure for that. But for something simple like I guess even going skiing, wearing like wrist guards or something like that just would be a good idea. So that's all I could really.
So here's kind of a question out of left field. Like foods, do any like foods like adversely affect the hands? I guess like, gout.
Oh, that's a good question actually.
Yeah. Well, certainly, gout could be a potential issue. It's not as common in the hands, but it occurs.
I still have to eat my asparagus.
Yeah, but so the whole dietary issue with gout is actually not as clear cut as you would think.
Really?
Patients come in and they say, I have to stay away from shellfish and alcohol and basically anything that has purines in it or increases purine levels, or uric acid levels, I should say. If you look at the data, it's kind of all over the place on that.
A little gray.
Yeah, it's a little gray. Yeah, I mean, there might be, medical professionals listening who will vehemently disagree with me, but I generally don't tell my patients to avoid anything in their diet unless they find consistently it makes a difference. So, I do have patients who come in and they say, every time I have shellfish, I get a bout of gout. Okay, avoid shellfish. But then I have other patients say, really can't link it to anything that they're eating.
That's interesting, huh?
They need to be on allopurinol or one of the newer meds to decrease their uric acid.
Oh, so it's not as clear cut. So.
No, I mean, from our medical perspective, we don't think about it as being as clear cut.
Oh, okay.
Yeah. So, I mean, like I said, there are patients who it is very clear cut that they have certain things in their diet and they can guarantee the next day they'll have gout, a gouty attack. But there are other patients it doesn't seem to be associated.
Got it.
So it's interesting.
Interesting, yeah.
So what about these injuries? Like what kind of actual injuries do you see and what are the most common?
Yeah, so I would say fractures, broken bone is definitely one of the most common things that we would see.
My brother used to play football and he broke his finger once. It was like sideways. The coach just came and straightened it back out and threw him back in the game. So that's never a good thing, right?
Yeah,
Yeah.
that's what that sounds like.
Yeah, you just kind of pull it back in.
Yeah, that's what they did.
It doesn't sound like something you'd want to experience, but it probably hurts a lot more being dislocated than you have a few seconds of severe pain and then it's back in. And
Right, and you have the adrenaline rush, so you
Yeah,
probably don't feel
right,
that much till
right.
after the game.
I see a lot of now that we're going to get into the winter weathers, snowblower injuries. In the summer, you see lawnmower injuries,
Oh yeah,
table saw injuries.
Ooh.
So here's a couple points that I will just throw out there to prevent these, because I've seen a lot of these over the years, and I can't do anything with them. Of course, they end up going to you, or your colleagues. But a snowblower gets stuck. Never put your hand in there because it's under a lot of tension, and sometimes there is something in there that is blocking the blades from moving, and you get your hand in there and it lets go. Bye fingers. Lawnmower, I mean, I don't know why people put their hands under lawnmowers. I see every couple of years, I see someone who loses a few fingers. Table saws, yep, I see that all the time
Right.
too. People, when you operate a machine like that, and I do some woodworking, you have to think about every operation you do. So one cut before you do it, you have to think about what you're doing. You can't just be lackadaisical about it and do it. And you think about what you're going to do, how you're going to protect yourself, etc. You never have alcohol with power tools. You'd be surprised how many people drink and use their table saws and lose fingers. But
right.
Yeah, you just have to. And the people who lose their fingers aren't like the people who are new to the tools. I've seen this all the time because they have like a lot of experience. They don't have the people who are new. They're really afraid of it, so they're careful. It's the people who've been carpenters for like 20 years and they're just not thinking, and they lose a thumb.
Right.
Blade.
Yeah. Get a little too comfortable with
They
it.
get comfortable. You can't get comfortable with those machines. Those machines are very scary.
Yeah. No, I've seen it.
Yeah.
Dr. Mahmood, does that fall under your scope too, sewing digits back on?
Yeah. I mean, so it is part of our training, but I just don't think like if somebody came to the ER like that, they would probably go to more of like a high level trauma center
Yeah.
versus saying it's like if somebody had like a chopped off finger, they'd probably send them to like a
But that could be either a plastic surgeon or a hand surgeon would
Yep.
do both, right?
Yep.
I mean, either one could do that.
correct.
Okay. Yeah.
When that happens, do they gain back, or is it all case independent? Like if it's like
really,
a clean cut?
It's really dependent. There's a lot of literature that shows that it really like so we define the finger in terms of like for
Yeah.
something like that, like a zone of injury, like a zone 1 is like just the tip of your finger.
Mm.
Zone 2 is like kind of like this area, and a lot of literature shows that doing like if you're going to reattach a finger in this zone, if it's like an isolated digit, it may not be worth it because the outcome of that surgery, they're just gonna have a stiff, painful finger,
Yeah.
and it's not gonna be that functional for them. So there's certain indications where you absolutely should try to, it's called replant the finger like a thumb, because your thumb is so important.
Yeah. You need
Right.
opposable
Yeah,
thumbs.
or if you have like multiple
TB rebel.
digits, or a pediatric patient, you have to
Yeah.
you have to give it a shot. But if you have like a crush injury,
Mm.
like a traction injury,
Yeah.
or like a segmental injury, those things it's generally not a good idea too.
What happens if you go through the joint? That must be almost impossible to fix too, I'm guessing.
It
Like with
depends
a
on
table saw through the joint.
So if it was like
Complete amputation.
right, if it was really distal,
Mm.
probably would say it's better off doing a soft tissue coverage thing later down the line. But you'd be surprised. You could have some success with that more proximal too.
There was a resident that I remember way back when I was in training. I don't remember the story of how she lost her thumbs, but something happened with her thumbs. They did a transplant of her toes, her great toe.
Oh wow, yeah,
Which was, pretty interesting because it's hard to function without opposable thumbs.
right.
And, it looked a little funky, but it worked.
Yeah, I think with that surgery, the best outcome you're looking for is like it works like a post,
Yeah.
basically, like because it's hard to grasp just like this, but like
Right.
if you have like something like even if it's just like a stiff thumb, like that's so much more functional, even just writing or things like that,
Yeah.
than having nothing there.
Yeah. I mean, how do you hold chopsticks? I mean, I'm serious. I mean, you
Yeah.
kind of need that, right?
So, anyways, Dr. Mahmood, let's talk about with the injuries, a sprain versus a fracture, and the different types of treatments. And how do you like if I fall down? Not because I'm old, maybe because I'm playing soccer. If I fall down and my wrist swells up, like, is there a way to tell if it's a sprain versus a fracture? And do I have to go into the ER and maybe sit there for 6 hours? Or what can I do with this?
You could go to your primary care doc too. We could get an
Yeah.
X-ray, check you out, do an exam. Maybe you don't even need an X-ray. It depends. But.
Yeah, that's a really good question. I mean, for certain people, like it's like if you have like a minor fall, something like that, it's more likely than not that it can be a sprain. But there's no way to tell unless your arm is completely crooked, which we do see obviously, whether it's broken or not. Like I had a patient today who had what we call a non-displaced fracture, meaning like the bones, there's like a fracture line, meaning it's broken, but it's not shifted out of place at all. So there's really no way to tell other than getting an X-ray. So when in doubt, if you have a fall, if it's been hurting, I would just go to ER, go to your primary care doctor, and get an X-ray. It's better to be safe for that sort of thing. Yeah. Because the treatment is very different. If it's a sprain, you can wear a brace for a couple. Or if we're talking about like a wrist sprain, wearing a brace for a couple of weeks is totally fine. But if it's broken, that needs like a longer period of immobilization and serial follow-up to make sure it's healing. So.
And then if it heals wrong, I mean, there's a risk of that too, right?
Yeah, definitely.
And then
Yeah. Sometimes, patients who fall on an outstretched hand, like they're rollerblading or whatever it may be, or you just normally catch yourself, they'll end up with these fractures in the wrist. The bone here is the scaphoid. Tell me if I'm incorrect.
Yeah.
But it can be very easily missed, and you end up with arthritis afterwards. So.
Oh.
Yeah.
How does that work?
How do you get arthritis? Or.
Yeah.
Well, we'll ask the good doctor that.
Sure, yeah. So, you bring up a good point. Scaphoid fractures is one of those things that, exactly like you said, fall or something that where you're on your outstretched hand, and it's not like it'll almost feel like a nagging pain for a while, like for weeks or months. You just have the swelling and this pain kind of right over there. And you'll get an X-ray and it looks normal, and then a few weeks later it's still hurting, and then you get an X-ray, then it's like shifted out of place, or just then you can kind of see the fracture line there. So like exactly like you mentioned, it's one of those things that's easily missed. Even in the ER, it just doesn't show up on the X-ray. So that's why it's better to be safe if there's concern for that from the ER provider, and they usually put them in some sort of immobilization and have them come see us,
because it can become a long-term problem.
Yeah,
if
definitely.
It's missed.
Is a hairline fracture a big deal?
So it depends on what. So a hairline fracture, I guess, is what we call, like we were just saying, a non-displaced fracture. And it really depends on where it is. So if it was of like the scaphoid, that's one of those bones that doesn't have the best blood supply. So it takes a long time to heal. So for that, it's a big deal because you have to be immobilized for a while. Where if you have a small hairline fracture of the tip of your finger, that's not as big of a deal. So it really kind of depends on where it is.
I think I remember that's probably why there's a development of arthritis in that, with that fracture, if it's not treated, because of the blood supply issue.
Right.
Disruption of it.
Yeah, so the blood supply issue makes it not heal, and then that can lead to, because that bone is important because it's connected to all the other smaller bones in your wrist with ligaments, and that can disrupt the biomechanics of your wrist, and that kind of leads to progression of arthritis.
Right. I've seen patients who have bad arthritis in their wrists, and they like literally can't even move it either, any direction.
Right.
And I always wonder how they got it, because it's really there has to be some type of congenital issue, because they're 55 years old and they have immobile wrists.
Yeah, certain people just kind of are unlucky like that. You'll people who have knee replacement when they're like in their 40s. It happens.
So a couple of years back, I tripped over my dog and broke my toe.
Okay.
And I mean, the only thing I really did was just taped it up to the toe next to it. Is there any different treatment for little broken toes?
Yeah, so I mean, a lot of that is similar. If you broke your finger, if it's, as we mentioned, if it's like non-displaced or if it's like pretty stable injury, what we call buddy taping, exactly what you did, is similar. It was what we would recommend for that. Yeah,
that's what I did. I buddy taped.
Yeah, but a lot of times that's why you need the X-ray to see if it's really shifted out of position, if it needs something else.
So after you trip over your dog Buddy and break it. So we can buddy tape you down.
I don't think that was what the conversation was all about. So can you tell us a little bit about the most complex case you've ever had or have been a part of?
Sure. Yeah. So as I mentioned, I just started practice. So a lot of the cases that I've seen were in residency and fellowship, and definitely had some really interesting ones. One particular one that stands out to me was during my pediatric rotation that I had in Connecticut Children's Hospital. We had a 4-year-old kid, and we were just talking about congenital issues. This patient was born without a thumb, so absent thumb. And as we were just talking about, your thumb is so critical for like it's been described that 50% of your hand function just comes from your thumb. So it's really important for them, obviously. So the surgery was actually turning it's called a pulsization, which means that you take their index finger, you kind of dissect around it, and you kind of shift it into position to function as a thumb. So so it was a really young kid, and it was like if you think about it, like it's definitely gonna be very impactful for him growing up.
Sure.
Like, having full function or as close to better function with something like
So
that.
you're moving the finger over and it becomes a thumb, and so then
Yeah.
you have like 3 fingers and 1 thumb.
Exactly. Yeah. So if your index finger is obviously longer than your thumb, so we have to shorten it, dissect the muscles and the tendons around it to make sure that, because you have muscles that are specific to your thumb as well, and they do certain maneuvers like adduction, abduction, flexion, extension, things like that, and opposition, which is like bring your thumb across your palm. So you have to position the finger and shorten it in a way that it can function as your thumb.
Why did they wait till 4? Because that's when those bones were developed to a point that they could work with them?
Not necessarily. Patients, so for these congenital hand issues, we generally, so people do surgery at different ages. Most people would recommend waiting till like at least 1 year of age just because of the anesthesia risk. But this patient had surgery at 4 for whatever reason. I think they would have had it at a younger age, but there was some sort of like a issue with, yeah, it was like a social issue that kind of made them wait that long.
Sure. So my last question is, when you're in the ER and you have this great big infection going on, why are hand surgeons called in for that? Like, what's going on that?
If you have an infection in your hand, you mean?
My nose.
No. I'm just asking. I mean, I'm trying to just be more specific for the audience. Okay, so you go to the ER, you got a hand infection.
Yeah.
Why would a hand surgeon be called? Okay.
Yeah.
That's a good question. No, that's
Is that legit? Can he
very-
answer it?
no,
Are
it's-
you sure? Did it pass the test?
No, that's very legit. I just wanted to just clarify what you were getting at, but that's a very
Yeah.
legit question, of course.
Thank
Anything
you.
you ask is legit.
Yeah, so definitely one of the most common things we see. So in terms of infection, there's obviously different like grades of it. A cellulitis would just be like a superficial infection of like the skin or subcutaneous tissues. An abscess is like a collection, and generally when you have an abscess, which is one of the most common things we see, it needs to be drained. So that's generally why they would call us. But a lot of times that's something that thankfully can be done at the bedside, which means we put some local lidocaine or something like that in the finger or the digit, and then we just make a small incision to help drain that. And generally those don't get better unless you sort of make a small incision and do that. But a lot of times it can be a more serious infection of the deep space of your hand, and then that's more concerning that a lot of times needs to go to the operating room. So to answer your question, when they call us to the ER, it's sort of to make that determination, whether this is something that can be just treated with oral antibiotics or IV antibiotics like a cellulitis, or if there's an abscess or a deeper space infection that needs to go to the OR, or that needs something at bedside.
So for those people that may be sitting at home with something brewing, can we go over the signs and symptoms of an infection and what looks suspicious? Maybe you should get checked out.
Sure. Yeah. So if they develop, that's a really good question. So like if I would say generally that's something that's like more rapidly progressive, like over 12 hours. If they got like a small cut on their hand, they noticed that there was like, it became more red, swollen, really painful. It hurts to bend the digit at all. If it's like diffusely swollen, I think those are really like signs that like you should come to the ER to get checked out. But generally you'll see it doesn't look right. Like it's red, swollen, painful. Anytime you move the finger at all, it's painful, or you remember a recent bug bite or like a small cut, and usually that's the cause as well.
Yeah, and this stuff can progress pretty quickly too. Particularly if you have the quote flesh-eating bacteria, which is out there. And people lose limbs because of it in a very rapid progression. It doesn't take long.
Is that in this area?
Yeah.
Where do you get that from?
Where do you get it from? I mean, it's bacteria that probably the person is colonized with, I'm thinking, and then they have introduction of the bacteria by a small cut, or it might even be a microabrasion or something small, and it just gets out of control. A lot of patients who have that have other underlying medical issues. They may be diabetic, or which is it essentially makes you immunocompromised to an extent. Your ability to fight off infection is much less. But those infections can be rapidly progressive, and people can require amputations if they don't have it addressed quick enough.
Right. Yeah. Thankfully, it's pretty rare, but it certainly does happen. And those patients are like definitely feel ill. Like a small cut on your hand causing an infection, you're not going to feel like feverish and like have sweats, but somebody like that will definitely feel like systemically ill.
I mean, it's interesting. I mean, we cut our hands probably all the time, right? Because they're at risk. And, you don't often see really serious. I mean, of all the times we cut our hands, most of the time it heals
Right.
without
right.
intervention. But then once in a while, you do see these types of things.
Yeah,
that take
certainly.
place.
It's definitely occupation based. I would say like
Mhm.
people in the food industry or like auto mechanics, things
Right.
like that. I think they're generally their occupational exposures predispose them to kind of developing something
Yeah.
like that.
That's another reason why you always have to sharpen your knives in the kitchen. Working with a dull knife. No, I'm serious.
You're right.
Working
No,
with
you're
a dull
right.
knife is very dangerous.
Okay.
You just sharpen that knife.
Yeah.
That's my message.
Yeah.
Okay, there you go. Yeah. Or just not using knives.
How else are you going to cut a tomato? You're going to take out your scissors?
No, you just order out or something. I don't know.
God, this has
That's why-
gone off track.
Yeah.
So, Dr. Mahmood, how do people contact you if they want to continue this conversation or see you
Sure.
for follow up?
Yeah, happy to see anyone. My clinic is down at 277 Pleasant Street, so just down the hall or down the street right over here.
Nice.
But yeah, we're on the first floor, Suite 101, and just started this or last month, and the doors are open. Happy to see anyone in the
Nice.
area.
And they can either call directly or they can go through their primary if they need a referral or whatnot.
Yeah, exactly. Yep.
Yeah.
Yeah.
Very
And
good.
then, what is the one message you'd like to leave our audience with?
Oh, I guess just take care of your hands. Don't you feel like a lot of people when they get an injury, they appreciate how much they needed them.
Oh, yes.
Don't
Yeah.
stick your
Yes.
hand in a snowblower this winter.
Yeah.
That's your message.
That's a really good one.
Sharpen your knives. That was my message.
Yeah. Yeah. No, but there's a lot of injuries that can occur, no doubt.
Yep.
All righty.
Some of this stuff is preventable, some of it's not. But
Yeah.
yeah. So, well, thank you very much. This was
Appreciate
great.
it.
I mean, I learned a lot. And
Yeah, me too.
I'm sure our
definitely.
audience did too. So I want to thank you
I appreciate it. Thanks
greatly for
having
being
me.
on our show. It was really quite interesting, and we'll put the contact information on the notes for the show so people
Oh, awesome.
know how to contact you, and that would be great. And excellent. So thank you everyone for listening to our show. If you'd like to become a sponsor, please contact us at 774-319-4230. Special thanks to Ron Gamache for our intro music and the BioSkills of Northeast for producing our show, and of course Bay Coast Bank, which is just right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. And of course, thank you, Dr. Mahmood,
Thanks
for coming
again.
on the show. We really appreciate your information and your
Your
expertise, and
Anytime.
we enjoyed it.
Thank you again.
We'll have you on again at some point, I'm sure.
Looking forward to it.
Take care,
Great.
everyone. Bye.